So thanks again for being here. I'm sorry for my voice. I could not predict the fact that I will have any viral infection. But in any case, I will try just to emphasize some important things that we're doing every day when we take decisions, and particularly regarding the prognosis and prediction parameters for the early adjuvant situation. So this is a first case. It will be the only one, but I want your advice about that. Just look, the age is 52. There is no particular personal or family history. And at the end, she had lumpectomy plus sentinel node biopsy. It's a PT2 of 23 millimeters, node negative, grade 2, estrogen receptor highly positive 90%, progesterone receptor 30%, HER2 1 plus, and Ki67 at 20%. PT2, N0, grade 2, estrogen receptor high, progesterone 30, HER2 1 plus, Ki 20%. So my first question is, what will be your attitude according to tumor characteristics? 1, adjuvant chemotherapy, radiotherapy, and endocrine treatment. 2, avoid chemotherapy, just using radiotherapy and endocrine treatment. Menopause woman, T2, 23 centimeters, grade 2, estrogen receptor 90%, progesterone 30, HER2 1 plus, Ki 20%. Whoops. Great. So we will have the answer. Okay, so the majority of you will not consider adjuvant chemotherapy. Great. Then the second question is, if it's easily available for you, and we have seen that 2/3 of you have potential access to multigene assays, will you consider in this situation a signature? Will you ask for a signature? 1, yes, 2, no. PT2, 23 millimeters, node negative, estrogen receptor, grade 2, estrogen receptor 90%, progesterone 30, HER2 1 plus, Ki 20%. Yes, I ask for a multigene assay. No, I will not. Okay, so you're pretty sure that you don't need chemotherapy, but you're not so comfortable. You will probably ask for a multigene assay if you have access to this tool. Then the next one is trying to define what is the gray zone and what I've called the different attitudes regarding the gray zone. And it's a privilege when you are older and older that you have some interesting reminder of what was the history of breast cancer. This is one of my very first presentation at the multidisciplinary board, where the NSIBP group published in GNCI in 2001 a very provocative conclusion from NSIBP trials, just stating that maybe it's possible that all the patients need adjuvant chemotherapy independently of the tumor size, because this is just focusing on small tumor, node negative, less than 1 centimeter. And you see for the relapse-free survival, on the left side, it's the estrogen receptor negative. On the right one, it's the estrogen receptor positive. So chemotherapy might impact even here. And regarding the overall survival in the estrogen receptor positive, on the extreme right side, there is still a signal that maybe adjuvant chemotherapy play an important role in this subgroup of patients. Regarding that, you have to remember that before St. Gallen and before a lot of discussion at that moment, it was close to mandatory to say that all the patients need to receive adjuvant chemotherapy. So the different clinical trials group were going in 2 different directions. The first one was what we have done not only in France, but in other countries, try to desescalate using chemotherapy. This is just to remind you, this was a French trial, PAX-06, just looking at the PAX-05, looking at 4 courses versus 6 courses of FEC. Of course, the results are not at all interesting because between 4 and 6, you will not see any huge difference. This was just the point to show you what were the inclusion criteria. At least 1 centimeter and one of the other parameters that might be grade 2 and enough. Another statement, and this is the result from the ABCSG group, was to say, you know, I don't need chemotherapy for all, I assume it, And then you have here the trial just exploring different endocrine treatment strategy, tamoxifen plus anastrozole versus tamoxifen alone, for grade 1, grade 2 invasive ductal carcinoma or infiltrating lobular carcinoma. And the point was that it seems that there is no too much difference between the endocrine treatment strategy, but there are some prognostic parameters that might influence the outcome, and among them, of course, node positivity, tumor size, and different classical pathological parameters. So trying to explore this gray zone, you see that the groups are going in two opposite directions. One is desescalating chemo, another one is assuming that we don't need chemo in some subgroups. So regarding this point, and trying then to integrate new technologies and new tools, if you look what was the development of the signatures, then the two options gives two different strategies. One, assuming chemo as a standard and desescalating chemo was developing predictive tools for chemotherapy impact. This was potentially what was done with the Oncotype DX and MammaPrint. And the other one was to develop prognostic tools, assuming that all the patients do not need chemotherapy and we just need to know a better prognosis and evaluating better prognosis. So look what we have regarding the strategy of developing these tools. And I will simplify it, we can discuss after. The first hypothesis is prognosis is the driver and is enough. I will use one test. This one is the EndoPredict. And the results are here from several trials. I've just focused on this one. The first thing is that because prognosis is the driver, of course, using these tools, you need to integrate the classical pathological parameters, which are the tumor size, the node involvement, and then the added value might be interesting when you look at the signature. But the other point is when you try to define if this tool is enough to consider chemotherapy or not, you see that there is no demonstration of chemotherapy impact using this tool in retrospective analysis. So the conclusion is that there is no demonstration of correlation with chemotherapy impact, even if you probably better define the outcome and the prognosis. The other hypothesis was the cancer subtype is a driver and it's enough. And we have several publications showing that probably the prognosis is different according to luminal A, luminal B, et cetera, et cetera. So the PAM15 was an interesting approach, and they have also tried to evaluate if there is a correlation between chemosensitivity and the fact that the tumor is close to luminal A, luminal B, or another one. And again, they failed to demonstrate that there is the correlation between chemotherapy impact in this retrospective analysis. So the conclusion was that yes, probably the prognosis is better defined, but it's impossible to clearly define the chemotherapy impact according just to the way we define the subgroup according to the subtypes of breast cancer. Then the third hypothesis was based on desescalation. And this was the hypothesis driven by the two prospective trials, one with MammaPrint and the other one with Oncotype, trying to integrate not only the biological hypothesis, but also to confront it, from one side the prognosis, and from the other side the prediction of do chemotherapy works or not according to this prognosis. The trial were published, you know very well, it was presented by my colleagues before. On the left side you have the MammaPrint results, on the right side you have the Oncotype results. I'm not comparing them at all, but just to say that they are addressing a little bit different questions, but in any case, the conclusion are this one. There is a gray zone that is still here. If you look at the MammaPrint trial, the MINDACT trial, then the conclusion is that yes, the prognosis is pretty well established, but there is still a gray zone regarding the clinical high risk and the impact of the chemotherapy if they are low genomic risk. There is an uncertainty about the impact of the chemotherapy that might be useful independently of the fact that they are low genomic. And on the right side, it was mentioned by my colleagues, in the youngest population, less than 50 years, even if the prognosis seems to be better in the gray zone, they still benefit, probably, some of them, from the chemotherapy. The question is, do they benefit because they do not benefit at all from the endocrine treatment or not too much? This is another question. So this is what you have seen several times, the result from the tailoring. And just to show you how actually we can expect the outcome of the patient using these kind of tools for the future. And I'm mentioning that because if the strategy to optimize the treatment will integrate two things, one the prognosis and the other one the prediction, we will probably improve the outcome of the patient and also decrease the risk of overtreated or undertreated patients regarding the also side effects of the different chemotherapy regimens. So my last part is to say that this is not a personal vision, and you have to go back to the new version of the AJCC classification for breast cancer. Not the last one, but the version before, the 7th edition you have here, just show that according to the stage, you have on the table what you might expect as a 5-year relative survival rate. And you see, for example, that for the stage 3, you are pretty close to 50% relative survival rate. Interestingly, in the new version, the 8th one, there are very, very important messages. And these messages are for prognosis and prediction, what I think. The first thing is that they have integrated the potential value of this multi-gene assay, as you see here, with the level of evidence according to the demonstration that you have on the different trials. You have first the Oncotype assay and then the other ones that you are here. Then the second thing is this table, and you have the classical staging according to the tumor size and the node involvement, but you have to ponderate this with a risk profile. And what is interesting is look on the upper side, on the top of the slide regarding the factors. You have 3 factors. One is the grade, the other one is the estrogen receptor status, and the third one is the HER2 positive status. Be careful, HER2 positivity is now clearly a determinant of low risk. It's still a bad prognostic parameter, but it's a very high predictive parameter of sensitivity to chemotherapy and particularly to anti-HER2 treatment. That means that if you care about how to optimize treatment, you have to integrate the prognostic parameter, but of course the prediction of efficacy of the treatment or not efficacy of the treatment. And this explains that when you look at the stage 3, for example, you have some patients that are very close to 90% of 5-year disease-free survival, which is totally different to what we have previously in the 7th version. So regarding this integration, they have also integrated the Oncotype's DX score, if you have less than 11, to be one of the parameters that give you a strong signal of very good prognosis. And probably in the future, we will have a lot of discussion to integrate these genomic tools with the predictive value to try to optimize the treatment and again increase and optimize the outcome of the patient. So back to this patient that I've presented to you. This is a real case. So we asked for a test, and this is the result from the Oncotype DX. The recurrence score is 37. So now my question is, regarding these results, what will be your attitude according to the treatment choice? 23 millimeters, grade 2, estrogen receptor 90%, progesterone 30, Ki-67 20, HER2 1+, recurrence score 37. 1, I will use chemotherapy. 2, I will not use chemotherapy. Okay. So I think this was my probably last slide. Thank you very much.